I'm doing one of my favorite procedures, which is called Micropunch Blepharopeeling.
I love the fact that your video has caused some controversy. Why not just do a blepharoplasty?
I recently had one of my videos go viral, this one here. In this short video, I'm doing one of my favorite procedures, which is called Micropunch Blepharopeeling. And I got a lot of questions, really interesting questions, and I wanted to go over those with you today. And some of the questions I've received are, number one, why not just do a blepharoplasty? Number two, why is this not considered surgery? 3, why are you doing this procedure? 4, how is this considered non-surgical? And why would anyone want to do this? And in fact, there was even an oculoplastic surgeon who stitched her response into my video and gave her reasoning why she didn't think it was an appropriate procedure and that blepharoplasty was the gold standard. But I actually disagree with that. And so I thought it was a really good opening, though, to start a conversation and answer these questions so that we can all learn together. Hello, everyone. I'm Dr. Melissa Chiang, and I'm a board-certified dermatologist, and I want to welcome you to our first episode of Unfiltered MDs. Since there were a lot of questions after my viral video about micropunch blepharopeeling and how to compare and contrast that with a traditional blepharoplasty, I am here with my husband, my practice partner, my soulmate, my workmate, Dr. Young Cho, who is a board-certified plastic surgeon, and we are going to talk about micropunch blepharopeeling today. And I want to welcome you to my podcast.
Thank you.
Even though we're in your podcasting studio. And so I'm really excited about this because I think we share a lot of work moments where we're discussing from our different specialties a solution to something. And in this case, we get to share with our audience the kinds of conversations we have. And I know they've been really helpful for me.
I think it's, I love the fact that your video has caused some controversy because it opens a chance for a discussion. I think some of the questions that I think as a surgeon, the question is this considered surgery or not, right? So that's a very interesting question. So it's a definition of what do you consider surgery, right? So some people think anytime you go through the skin, it's considered surgery, but at some point you go through small and small and small and small enough that it might be, is it really non-surgical? So is microneedling considered surgery? And most people would probably say no. So that's a pretty clear non-surgical, even though needles are penetrating the skin.
So the way I'm thinking about it is a little snip generally is non-surgical. I think of surgery, especially plastic surgery, as you're cutting out and you're shaping. It's almost like you're tailoring a dress. And so things are very aesthetically put back together. Whereas in my micropunch blepharopeel, I am snipping out skin to shrink it, but I'm not shaping it. And I'm not having 100% control over the final result.
Yeah.
So that's why in my mind it was non-surgical.
I think part of the other controversy is why not just do a blepharoplasty? And I know in my world, when we're doing a blepharoplasty, to your point, we're shaping the upper eyelids. We're sometimes doing something to the deeper structures, which a micropunch is not touching any of the deeper structures. It's just epidermis, dermis. I think the distinction is when I just remove skin and do some deeper things, I'm not doing anything to the skin that remains behind. So one of the big benefits of a blepharoplasty is to a very fine incision, and let's focus on the upper blepharoplasty for now. A very fine incision is placed, and it's usually placed in the eyelid crease itself. And with that, we're able to remove the appropriate amount of skin. It's fairly precise. We can treat the underlying muscle if needed. We can treat the underlying fatty tissue as well if we need to either remove or reposition some of that. But we can also address other components such as if there's a little bit of lid ptosis, then we can address that through that same overall procedure, and that's all considered surgical. But we're also often evaluating the brow. So if the brow is also ptotic, meaning it's descending down with the aging process, then we can fix this to a higher position. Sometimes we're doing it through the same incision. Sometimes we're making external excisions to combine it with our blepharoplasty.
So I think the thing that's really different about the micropunch blepharopeel is that it's really focusing on the skin. And a lot of times what people are noticing around the eyelids is that skin is very thin, it's crepey. Oftentimes it has some pigmentation, and the micropunch blepharopeel helps with all of that. Including in my practice, one of the things that I do is I will actually peel all the way to where the crow's feet end so that we can rejuvenate that entire skin. If the eyebrow is low, I peel the eyebrow too because we get that tightening of the skin. So I think these procedures are actually very different. They treat different things they can be complementary. And in fact, I know there are a lot of people, and I've been telling you that we should combine this together. That will combine surgical with non-surgical, because then you get the nice shape, possibly increase symmetry, and then the beautiful skin, which is so important as well.
Maybe this is a good time to talk about, you're talking about skin quality. So one of the things I often do with my surgeries is I might combine it with a fractionated laser resurfacing like CO2. So how would you define the difference between a fractionated laser that I might combine with some of these procedures versus a peel? And I know there's different depths of peel that might also affect your answer.
I think for the deep peel, which really goes to that second layer of the skin, which is called the dermis, it is very rejuvenating for the skin. It's regenerative. So even many years later, you can see that bright band of collagen that has been formed. And there have been studies to show that that band is thicker from a deep chemical peel performed well than from a fractionated laser. And so I think the limitation of the peel is that there's more downtime than with the fractionated CO2. But secondly, I only do this peel on skin types 1 through 3. Do you do a light fractionated CO2 on darker skin types?
Typically, it's in that same Fitzpatrick skin type, and that 1, 2, 3, the lighter skin tones. With the darker skin tones, I'm guessing same with the peel versus the laser, there's a risk of hyperpigmentation where things can actually get darker. Is that fair to say?
It's kind of true, but kind of not true. There is an initial phase of potential hyperpigmentation. Typically that lasts even as long as 6 months, but the phenol in the peel actually makes the skin lighter. And so that's a really big advantage. And I've actually had one patient that had really dark circles around his eyes, and we did the peel, skin type 4 to 5, and his skin is much lighter. So he does have a little bit of irregularity in his pigment though. So that is the one consideration that I think is important. But for people suffering with a lot of darkness, this peel can be quite impactful.
So maybe one other question is, what is the downtime? You mentioned briefly the peel may have longer downtime than a fractionated CO2, but what is the general downtime for a micropunch blepharoplasty or micropeel? What are you calling micropeel?
Micropunch.
Micropunch.
Little punches. Blepharopeel.
Blepharopeel. Okay.
Micropunch blepharopeel. So the downtime is the same with the blepharopeel. It's 2 weeks where the skin has a chemical injury. It blisters and completely replaces itself. So that is truly 2 weeks where your skin is replacing itself. But after that, 3 to 6 months, or even 6 months plus of redness, which is slowly fading. But all of that redness is an indicator that the skin is still responding to the peel, and the results actually get better after month 1, month 2, month 3. It's like so exciting to see the patients because they just keep getting better.
And when do you tell patients they're going to see the final results?
After all the redness is gone.
Which could be more than 6 months in some cases.
It could be more than 6 months, but in general, the rule of thumb that we say is 3 months of redness is worth 10 years of collagen. So that's very impactful. So the longer you're red, the more results you're going to have.
For blepharoplasty, I typically say budget a good 2 weeks of social downtime to allow your swelling and your bruising to go down. If I'm adding a laser resurfacing like a fractionated CO2 in the same areas, I say that the redness from that is roughly around that same time period. So I still say about 2 weeks of social downtime. And if there is any residual bruising or redness at that point, they can start concealing it with things like tinted sunscreen or concealer. What about the redness from a peel? What can they do?
The redness from a peel is also coverable with makeup. We found that green tint is very helpful. You can only apply the makeup once there is skin to apply it on. So that's at that 2 week time frame.
So it's also about 2 weeks.
It is also about 2 weeks.
So you would say about 2 weeks social downtime.
2 weeks of social downtime. Yes. You can do other things, but you definitely are not going to want to see anyone.
Yeah. After 2 weeks?
Or 2 weeks.
For 2 weeks. Okay. Got it.
But the other thing that I want to know if this is true for CO2, with the blepharopeel, the skin does not age as quickly as other skin. It kind of stays still for a very long period of time.
Yeah. So I would say with the fractionated CO2, part of the results, and to your comment of the longer the redness, the stronger the results, what I would say is fractionated CO2 by definition is leaving some of the skin untreated and is treating certain percentage of the skin by almost coring little columns of energy, causing controlled injury, and then waiting for that collagen elastin response to rejuvenate the skin. But because it's fractionated, it means that we're not dealing with 100% of the pigment. We're not dealing with 100% of the skin. But if I do multiple passes, I start becoming more and more, I'm applying more density of that injury. But there's a limit to how many passes I can do before I start causing too much injury. Whereas I think with the peel, you're treating 100% of the surface and it's just controlling the depth of that injury. Is that a fair way to think about it?
Yes.
Yeah. Which I think is why you're probably seeing with some of your more aggressive peels, a longer duration of redness. Whereas because mine is fractionated, the skin heals a little bit quicker because you've got the adjacent healing areas that allow to kind of help aid the injured areas to heal faster.
In fact, you're helping me to recall one of your patients who I believe had already had fractionated CO2. You know what I'm talking about? And maybe even a bleph. But then she came to me for a peel because she was still getting some fine lines, even despite Botox.
Yeah.
And she found that peel to be very impactful.
Oh, that's one where you're also treating, like to your point, treating the crow's feet and stuff.
Yes.
Yeah.
And she actually came back for us, like she wanted it. And she was a more is more type of patient.
Yeah.
So I would love, because you saw her.
No, she looks great. So I know who you're talking about. So I think there is a role for this multimodal approach. I think that's one of the things I really enjoy practicing with you because I know the scope of practice that I have complements really well with your scope of practice. Sometimes they're overlapping, sometimes they're just complementary. But I think in the case of the Micropunch Blepharopeeling, it's something that it rejuvenates the skin, and that's really primarily a skin tightening and skin rejuvenation treatment. And I think if I'm trying to distinguish that from a blepharoplasty, we're trying to reduce some of the redundancy and maybe treat some of the deeper anatomical structures that may help to create a more aesthetic upper lid region.
Yeah, I totally agree with you. I think we're improving skin quality with the Micropunch Blepharopeeling. We can help with redundancy to a certain extent because the skin does tighten, as well as we're removing those little blepharopunches. But that said, some of the work that I've seen you do when there's a little bit of asymmetry between one crease and another crease, and you can make those two symmetric. But when there is fullness that needs to be addressed, like under eye fat herniation, those are things where a blepharoplasty would be the ideal procedure.
So patient selection, if you were to say, this is my ideal patient for a micropunch blepharoplasty or blepharopeel, who would that be?
I think it's someone who is a generally a medium to lighter skin type, light eyes and light hair, not prone to pigmentation, who has crepey aged skin around their eyes. We're doing Botox and those lines are etched in. We really need to do something to help with the skin. That's an ideal patient.
There's a lot of physicians who have commented on your viral video, and I think you've posted on this more than once, and I think you've had reaction videos on some of your other posts as well.
People just love watching these Micropunch Blepharopeeling.
And I think it's stirring controversy, especially from the surgical community, because this is something that's new to them, and it's something that they're probably saying, we already have a great solution for this area. Why are you trying to create this shock and awe about this other procedure when there's already tried and tested procedures like the upper blepharoplasty? Tell me, how would you respond to it?
I think that the surgical community, because I've looked back in the literature, and there are definitely narratives from plastic surgeons who are including peels or who used to include peels in their eyelid rejuvenation protocols. But I think that peels are not as common today. These deeper peels are not as common today as they were 20 or 30 years ago. And maybe there's a sense that they don't know what the expertise is involved in applying a peel. And so it just seems like the wild, wild west. But there's actually, especially in the dermatology world, a lot of knowledge about the layers of the skin, the thickness, what are the endpoints we're looking for. So when you watch someone just paint a peel on, it might look really easy, but it looks easy. And if you get a good result, it's because you have that much knowledge, that much expertise, that much training. But maybe it's scary to watch someone do that and think it's uncontrolled.
That's a fair point. And you're briefly referencing literature. Has there been any studies that actually compare, let's say, a micropunch blepharopeeling to a blepharoplasty when it comes to the upper lids?
Yes. There was one study, randomized controlled with 22 patients, so a small number of patients. And actually, it didn't reach statistical significance, but the trend was that the patients were very, very happy. The micropunch blepharopeeling patients were actually happier than the surgical patients. And the physicians looking at the results were also happier with the micropunch blepharopeeling results. I shared that paper with you.
Yes, you did.
What are your thoughts?
And I think it's more, we see this in facelift surgeries as well, where if we reposition and reshape the face, but the skin is left untouched, if they still have this aged appearance. When you're able to do some form of resurfacing, whether it's through a peel or whether it's through lasers or energy-based devices, and you start refreshing the canvas of the skin or the facial envelope, it makes a tremendous difference. And I think that's probably what they're seeing in the paper, where you're treating 100% of the skin itself and causing some shrinkage, versus a blepharoplasty, which may be really just taking care of that excess tissue. The skin quality is probably what makes a difference. That's how I would be interpreting those results.
Yeah, and I think part of it is when people are looking at their eyes, it's not just the eye. It's like, I want to look awake. I want to look bright and energetic.
Yeah.
And they think that more open eyes is going to do that for them. But what's going to do it is the whole package.
Yes.
Yeah.
So that's a good question. When you were commenting earlier on who the ideal patient is, and you talked about the lighter skin tones and those that might benefit from kind of an improvement in the quality of the skin itself, what about someone who has ptosis, whether it's eyelid or brow? Is this something you mentioned a little bit about treating the upper brow area, but what about if they have eyelid ptosis? Does this help with that?
So my understanding of eyelid ptosis is it's really related to the levator muscle, and the levator muscle is almost like a Venetian blind, and the Venetian blind gets a little bit too long, and so it can't pull up as much. And as a result, that eyelid doesn't pull up as much, and it's always compensated for by the eyebrow, which will then become a little bit higher on that side. But this really treats the skin. So unless treating the skin somehow interacts with the muscle to help it, I do not think it would treat ptosis.
No, and I would agree with that. So I do think that there's definitely a difference between surgical options and doing a proper assessment and trying to identify. So if a patient's coming in because they feel like they look tired and that's because their lids are dropping down and starting to cover or encroach upon their pupil, then skin resurfacing is probably not going to be the right solution for that. That's where surgery really comes in as the primary option.
So to delineate that further from just saggy skin, with saggy skin, you are able to open your eyes, but you might notice the eyelid is like resting on the eyelashes.
Yeah.
But we're still able to see the majority of the iris, which is the colored part of the eye.
Yeah. Here's a question. And can you do an upper blepharoplasty with a peel? And you alluded to some plastic surgery literature in the past where they were doing combination treatments. But what is your thought on it?
The one that I was specifically alluding to was someone who combined a peel on the lower eyelid skin, typically several months after surgery, to give that additional rejuvenation. But yes, there are lots of people that are combining the two. And so if you have your surgical incision in the conjunctiva, which is like the wet part of the eye, you can do your peel at any time. If you are doing it into the skin part, you would ideally want to do the peel first, get the skin rejuvenated, wait for 6 months, and then do your blepharoplasty.
So this is very helpful because we're talking about the spectrum of the things that you're very passionate about, which is peels and all manner of peels.
Or just like skin rejuvenation.
And skin rejuvenation. And for me, it's really about what can I do to help restructure, reshape, whether it's herniating fat, whether it's excess skin, whether it's tightening the muscles, whether it's reshaping the eyelids or the brows and so forth. So I found this conversation very helpful and very illuminating.
I did as well. So one of the questions that's come up is, why not just do a blepharoplasty? Isn't it so easy? And you described the 2 weeks of downtime.
Yep.
So in your mind, if I were to ask you, what can your blepharoplasty not address?
So I would say a lot of patients with redundant skin are candidates for blepharoplasty, and they can see a really nice difference in shape, and you do have the 2 weeks of downtime. But what I will also say is that if they have other pigmentary changes or they just have really crepey skin to begin with, then the blepharoplasty will help to reshape it for a transient period of time. But if we're not helping to improve the skin quality, they may still have more of an aged appearance.
The one other thing about the Micropunch Blepharopeel is because that phenol does lighten the skin. Sometimes there will be this slight transition between where we have peeled and then the transition to the normal skin. Oftentimes it's perfect, but sometimes it is a little bit lighter there. Most people prefer that to having darkness.
So what about, why not just do a full face peel, including the micropunch?
Now, if I do see that someone has a lot of sun damage on the rest of their face, we will combine it with a medium depth chemical peel, because you can't have perfect baby skin here and then all of a sudden have all these freckles and sunspots. But the reason why I don't typically combine it with a full face phenol peel is because if I want the patient to be awake during the procedure, not to need cardiac monitoring, I am limited to a certain amount of body surface area because of the phenol. I know one of your questions was scarring. So the amazing thing about this peel is we can create all these little punches, but it heals scarless.
And why is it scarless?
I think it is because there is so much regeneration that is happening and that skin is completely replacing itself that there is no residual shadow from those little punches that have been removed.
Can you predict, if you did a upper blepharoplasty with a phenol peel, that the blepharoplasty scar, which already is pretty subtle and hard to see, but that would also be scarless?
So I think that, remember we talked about, usually there is a period of time between, if you're going to have a skin scar and your peel, you're not going to do those on the same day. But I think what we could do, if you have a patient that has a scar that's noticeable in the crease, after that scar is completely mature, you can then do a blepharopeel. And it does improve scars, surgical scars.
And skin quality.
And skin quality, yes. So if we were to sum up our conversation, I think it's not really about which treatment is better, but it's about what is the patient's anatomy, what are their goals, and what treatment best fits those goals. Would you agree?
Absolutely. It's about customizing a treatment plan for each individual patient that comes and visits with us. And I know if I'm sending a number of patients to you and vice versa, where we think the other may have a either better offering for that specific patient, or if we're planning to combine treatments together to get the best and optimal outcomes.
Yeah, that's part of what I love about working together.
Absolutely.
If you're curious about which approach, or if both approaches would work best for you, please see us for a consultation. And if you have any additional questions or comments, please drop them in the comments box below.
If you found this video to be helpful, don't forget to subscribe, like our video, and stay tuned for more in the series.
Thank you so much for watching, and look forward to seeing you next time.